Good afternoon and welcome to Kirklees Health and Wellbeing Board, which is a meeting being held online on Thursday, the 20th of January 2022. And welcome to everybody here who's in attendance. Can I remind everybody that this meeting is being videoed and recorded? Can I ask that if you wish to speak during the meeting, ask a question, please put it in the chat bar. When there are so many people, I can't see the hand up clearly at all as to who it is. And can I ask people in attendance to switch off their cameras, please? Just board members leave cameras on and put your camera on at the point where you're going to speak or comment as such. Thank you very much. So then, Jenny, have we got any apologies, please?
None received, Chair.
I am aware that Councillor Kath Pinnock has to leave early. She wants to come home and therefore needs to get a train, but she's valiantly coming to the first part of the meeting, and we can thank her for that. And can I also welcome James Griffiths from West Yorkshire Police? I believe this is your first meeting, so very much welcome. And just before moving on, I'd like to thank my colleague, Dr. Khalid Naim, for chairing the last meeting so ably and helping out like that. It's very much appreciated. If we can move on to the minutes of the previous meeting, well, not the previous meeting, the meeting held on the 30th of September 2021, which should be in your pack. I'm looking to see whether there are any corrections. Please put in the chat if you feel there's anything that we need to change or alter. And then I'm looking for approval from board members. If
Chair, can I just say the minutes should be the 2nd of December?
So, well, I'm reading off the script that you gave me.
Apologies. Yes, it's the 2nd
I thought it was unusual. I thought we mustn't have approved the September ones. So yes, it is. It is the 2nd of December as such, yes.
Yeah, and just to point out, the minutes will be amended to reflect that Dr. Naim chaired that meeting on the 2nd of December.
Indeed he did, and I'm very grateful for that. Again, thank you. So are we happy with those meetings for the 2nd of December? I've not seen any dissent apart from the alteration about the need for the chair. Are you waving at me, Khalid? You're okay. Right, thank you. So I'll take that as approval of those minutes. Thank you very much. So I have to ask if there are any interest to declare. If there are, can I ask people to fill in the form in the pack, which you should find in the pack, and get that back to the governance officer as soon as you can, please. There are no items that are not to be held in public, so the whole of this webcast is available to the public. Have we any deputations or petitions, Jenny?
None received, Chair.
Okay. Have we any public questions?
Again, none received. Okay.
So if I could then move us on to item 7, which I'm not sure it's a verbal update, COVID-19 update, and I suspect that it may well be Emily Parry Harris who's doing that as opposed to Rachel Spencer Henschel. Is that correct?
It is, Councillor Kendrick, yes. I've got a set of slides that I'm hoping that somebody is going to be able to share for me, and I'm just going to quickly talk us through those.
Thank you very much.
Thank you. And in my best Chris Whitty, I'll have the next slide, please. Thank you. Okay, so I've just got 12 slides that I'm going to talk us through relatively quickly. I think you've had a version of this presentation previously, and I'll remind everybody that there is a Tableau dashboard with data in the public domain as well. So this first slide is just to give a breakdown of uptake of the vaccination in our Kirklees population. It's given here in age breakdown, so you can see clearly a higher uptake of the vaccine in our older age population, and then a lower uptake as we move down the age brackets. You'll remember at the start of the vaccination programme, there was particular targeting of the older age groups because we know that age is the most significant predictor of a poor outcome from COVID. So a really, really good news story that you have to go down to the age 50 to 54 age bracket before uptake of the vaccine drops down below 90%. Still doing some fairly significant work on encouraging uptake of the vaccine in particular populations, and I've got a slide that I'll use to talk about that a little bit later. And the vaccination programme in schools continues. The second dose began delivery on the 10th of January, a really successful programme in schools in Kirklees as well. Next slide, please. Okay, so this is a breakdown of that same data, but by geography, and this has stayed fairly a similar picture throughout the life of the vaccination programme. The blue areas are the areas of highest uptake, the orange are those areas with lower uptake, so some very specific and targeted work happening in those geographies to encourage uptake. We've got a really good, robust vaccination programme being delivered in Kirklees now with well-established vaccination sites, well-established roles for the primary care networks and for community pharmacy, and also a series of pop-ups being delivered in particular communities where we would like the uptake to be even better. But that picture has remained reasonably consistent during the life of the pandemic, although we are seeing improvements in uptake of the vaccine in those areas that are currently coloured orange, which is good evidence of the fact that the additional efforts we are making are having the impact that we need them to have. Next slide, please. So this is just to show you the uptake of the booster by age. We know that taking dose 1, dose 2 and the booster is particularly important to give the full level of protection that we would like our populations to have. Not showing it for the 12 to 15-year-olds because they're not eligible, and there are very, very, very few people in the 16 to 17 age group who have been eligible for the booster as well. You can see that there is an improvement in uptake by age band, and again that means that we are providing the protection to those groups of people who are most at risk. Next slide, please. So this is a really dull slide, not dull in terms of the information it contains, dull in terms of the way it's presented, and we've taken the actual numbers off for the purposes of this meeting because some of those numbers are not in the public domain. But what it's essentially showing us that the darker the grey is around a population group, the lower the level of the vaccination uptake is in that group. So if you look at the 18 to 29 age group, sorry, in deprivation quintile 1 and in white British, that's the cohort where we, as a number of people in that population unvaccinated, we still have significant numbers left to come forward for dose 1, and we're using this data to inform the planning for the next phase of the vaccination programme. Next slide, please. Okay, so this is just to give us an opportunity to make a bit of a comparison to our statistical neighbours, and apologies that these slides weren't circulated in advance, but I'm sure you can appreciate that the situation is changing on a regular basis. What I wanted to do was be able to present you the most up-to-date data, but we can circulate these slides after the meeting. But what this is showing us here is Kirklees is the blue line roughly in the middle of that dose 1 uptake for our eligible population, and we're sitting very similarly for dose 2. What we tend to be seeing in the vaccination programme is where people have come forward for dose 1 of the vaccine, they come forward for dose 2 and they then come forward for their booster as well. So a real focus over the next few months on encouraging those people who have not yet come forward for dose 1 to do so. There's a lot of information on this slide, but what you've also got here is a comparator against our statistical neighbours in terms of how they're doing in terms of the vaccination programme, and you see that Kirklees shows pretty favourably in terms of the success that we've had with the vaccination programme. Next slide, please. Okay, so this is just to talk about infection rates. The Kirklees weekly case numbers have decreased by 40% in the latest week, and you can see that that downward trajectory is common across the local authorities represented in this graph here on the left-hand side. Kirklees are the blue line on this slide. You can see that there's clearly something happening in terms of infection rates in the northeast, and it looks to be a kind of a geographical cluster there. And then it also gives you the detail of the position that Kirklees currently occupies, and board members will be aware that we have occupied nearly every position in the rankings during the pandemic. We've spent some time at the top and we've spent some time at the bottom. We are currently 41st in the country. Next slide, please. Okay, and again, just a breakdown of cases by ward. You'll see in this week of the 6th of January, the cases by ward becoming much more even, much less discrepancy between those wards with the highest and lowest rates. Partly this will be reflected by changes in testing behaviour, but partly this will also be down to reduction in virus circulating. Next slide, please. And again, just a different way of demonstrating that data. So you can see cases by middle super output areas. We continue to see some clustering of higher numbers of cases into the North Kirklees end of the patch. And I think this patch down here is the kind of the Meltham area. Continue to see some differences in rate, but happily the case rates do appear to be coming down across the population. Next slide, please. The one age group where that's not quite true in terms of the numbers dropping is in the 0 to 11s. So the 0 to 11 age group is seeing a slight increase in their rates, and that's just something that we want to keep a very, very close eye on, because we know that what tends to happen is the 0 to 11-year-old age group gets it, they pass it to their older siblings, they pass it to their parents, and it progresses through the age groups like that. So we do just need to keep an eye on that. And while I've said it's very good news that the rates in our general population are decreasing, COVID has not gone away. So those very, very important messages about taking care, about being aware if you're symptomatic and accessing a PCR test, about taking a lateral flow test if you're going to be in a space with somebody who may be vulnerable, increasing ventilation if you're with people you don't habitually live with, hand washing, all of those messages that I've given time and time again over the last couple of years remain incredibly important. Some very good news stories coming out at the moment, but we mustn't take our relaxation too far, I suppose is a way of phrasing that. Next slide, please. Okay, and this just talks a little bit more about the school age rates that we're seeing. So, excuse me, rates have increased in the 4 to 10 age group, but are decreasing in the other age groups as well. That may be in part to the success of the vaccination programme in our secondary school age population. Next slide, please. And I made a little bit of reference to the testing rates dropping off over the last few weeks. You can see clearly here there was an increase in testing around the Christmas period that then dropped off as people started to come back to work. Next slide, please. That's it. Thank you. Happy to take any questions if people have them. Khalid.
Thank you. Thanks, Emily. I just want to reiterate what you just said, that we should not take it lightly. And any easing of restrictions don't mean that the virus has disappeared. The numbers are coming down, but the numbers went up when the restrictions were loosened. And then now, when we are going to do it again, there is a big risk the numbers are going to start going up. And the biggest thing is that one, disease prevalence is going to increase. The other thing is that the NHS will get overwhelmed with the need and demand, and that will be counterproductive for our systems. So we should be careful in lifting everything off. In my opinion, the advice should still go out as we should have all the precautions wherever is possible, and wherever we are in the crowded environment, we should have face masks on, and we should concentrate on hand hygiene, social distancing as much as possible, especially in crowded places, so that we can still remain safe and numbers keep on going down the trajectory. I don't want to be back in 4 weeks' time where our graph is going up and we are worried about our situation, and a number from 49 to go up in the graph. Thank you.
Absolutely, and thank you for emphasising that, Khalid. I agree. Thank you. Councillor Kendrick, you're on mute, but I think
sorry, Carol McKinnon, I think you're next, is what I was saying. My turn to be on mute.
Emily, just in terms of case numbers, it's interesting, isn't it? Because we no longer require positive LFTs who are asymptomatic to do a PCR test. And also we are reliant to a large extent on individuals reporting their LFT results online. So each of those things presumably leads to a risk of underreporting. What kind of margin of error then do you build in when you're looking at the case numbers? So I think you said they'd gone down by 40% in Kirklees. Is that building in an assumption about cases that are not reported, or is that not the case?
No, I haven't built in any margin of error. It's a very, very good point, though, Carol. And yes, I probably should have talked about that when I was talking about the testing. So at the moment, we don't require people to undertake a confirmatory PCR, because the level of virus circulating in the population had been so high, the efficacy of the LFTs had increased really significantly. So the confirmatory PCR was no longer required. But you're right, we are dependent on people therefore reporting their LFTs. It's an interesting question, actually. I'll ask next time I'm on one of the epidemiology calls whether anybody nationally is building in any of that margin of error as well. So I'll find out.
Thank you.
Thank you. I've got Beth Hewitt next.
Thank you. I'm just, in terms of, so we're talking about the relaxing of the restrictions, and just alongside the increase in the 0 to 11 groups in schools, I just wonder if there was any almost like preemptive support to schools. Obviously they can manage how they, whether they continue to wear masks in schools and mitigate the risks, but in terms of balancing that out with almost public perception, parents are seeing that there's a relaxation and then the school saying something different. I just wonder if there's any support available to schools to be able to manage that level of communication or not.
Thanks, Beth. I'm very conscious that Mel is on the call and has turned her camera on, as I thought she might. So I'll talk a little bit, and then I'm sure Mel will fill in the gaps. I'm sure the panel are aware that the changes to the rules around COVID changed very, very rapidly towards the end of yesterday, and we are still working with our communications team to finalise the comms that go into schools. We have taken throughout the COVID epidemic the role of supporting schools and working with head teachers to enable them to make the decision that is the right decision for them to make for their school population. I always like it when I make Mel nod in meetings. That's always a good sign. And we will continue to take that stance. At the moment, what we're being told by national government is that the use of face coverings in the classroom will no longer be required from today and in communal areas from the 27th. And again, that news came out very, very quickly yesterday, and I think it's fair to say, we're slightly taken by surprise by it. We will work with schools for them to do the thing that is right for them and their populations. But it'll just take us a little while to put some of those comms together. Mel, is there anything you would add to that?
Yeah, thanks, Emily. Now, I think you articulated that very well. We do. We're one of the few local authorities that kept our infection control teams, and you know, and schools have really benefited in Kirklees from that. Who knew that we would need them so much in the pandemic? So, schools where we are seeing outbreaks or higher levels of transmission rates get the support from the infection control teams, who go in, work with them on their risk assessments, and make decisions. So, what we the government have set out a criteria for which directors of public health can issue district-wide guidance, enhanced guidance around mask wearing and things like that. We haven't taken that because we haven't hit the criteria for which the government have set for us to make that decision. However, we continue to work with individual schools where we are seeing outbreaks in an outbreak management control arrangement, and where we think that will add will be beneficial, you know, where the benefits of mask wearing outweigh the negativity of mask wearing. And, you know, we do have a lot of children that tell us that it's really problematic for them in school. So we have to balance those things out. So we tend to take a school by school basis, and certainly there's nothing in the data at this point that would suggest we should do something different, but clearly we keep it under review. And if we think that, you know, going back to Dr. Kelly's position, if we think that we are seeing numbers raised, we will review that position as we go. So, but you know, there is some strict criteria been set by the government for which the directors of public health can make those sort of district-wide positions. The schools have really given us some great positive feedback about the infection control teams and the work that they've been doing. So, and as you know, in Kirklees we have every type of school, large schools, small schools, and so we've tried not to take a one-size-fits-all, because everybody's buildings are different, ventilation is different, the levels of vulnerability of children and their communities are different, and so it's been really important for us that we get down into a sort of a granular approach and take a school by school approach, but we're keeping a very watchful eye on it, please be assured.
Thank you, Mel, that's really helpful.
Thank you. Dr. Naim again.
Thank you. Thanks, Viv. Carol raised a very valid point, and in my clinical experience, I would say no more than 10% people actually go and have PCR tests done, and the majority of them do LFTs. And when we talk to them, they said that they tell us that it was LFT test, but they don't even sometimes realize that what's the difference between PCR and LFT. And the other thing is that the guidance, government guidance, they misunderstand. They think that they don't need to do PCR in any case, and then that's something which, you know, causes a lot of problem. And then the other thing is that, you know, they need to have, you know, some mechanism of people having to report LFTs so somehow by the QR code on that, you know, bit of plastic where they can upload it and with a positive or negative, so that it can be part of the overall prevalence records. The other issue we are having is about CMD use triages that we, you know, let me explain. You know, it's a COVID medication delivery units where we triage patients who are suitable for antiviral treatment or the antibody treatment. That they are only, it only kicks in if somebody has had a positive PCR with symptoms for a particular group of patients who are more at risk of developing, you know, the disease. And with PCRs having 24 hours of reporting times, and with the time limitation of it has to be started within the first 5 days of initiation of symptoms, it becomes sometimes difficult. People may not have done the PCR test, but they may be in that group which may benefit from the antiviral or antibody treatment. So there is a bit of complication there where some of those patients will be missed who can benefit with the test. So we need to have some sort of alternate method of recording those LFT cases and accept LFT as the concluding test if we think the LFT is sensitive enough. Thank you.
Thanks.
Thank you very much. I'm not seeing any others. Go on.
The final point that I would make, Councillor Kendrick, just before I finish, is that we need to reiterate over and over again that the vaccination programme remains an evergreen offer, and that if anybody is in contact with anybody who's not had their first dose yet, please encourage them to come forward. There'll be no judgment. There will be no repercussions of coming forward later. The vaccinators will be so delighted. It's almost a cause for celebration now when we see the first dose numbers going up. So anything you can do to talk positively, about the vaccination programme and encourage people to come forward, please do.
Thank you very much for that. I think that's a message all of us need to promote as such. But thank you for that, Emily. That's a very comprehensive run through the current situation. And I noticed Dr. Naim has put in the chat that we also need to promote COVID vaccination to pregnant ladies.
He's absolutely right. That is absolutely so important, and it's absolutely vital that pregnant women come forward. There have been some changes to the messages that have been given to pregnant women, and I think it's really important that we recognise that science changes its mind when it gathers new data, and it has gathered new data through the life of the vaccination programme, and we are now very clear that the risk of having COVID to an unvaccinated pregnant woman significantly outweighs the tiny infinitesimal risk that exists of being vaccinated. So particularly if anybody has any contact with pregnant women who are unvaccinated, please encourage them to have their vaccine, because it's so heartbreaking when they don't.
Yeah, absolutely. Thank you very much for that, Emily. That's very useful. Thank you. Can I move us now on to agenda item 8, please, the health and care operational pressures update. And I think Richard Parry and Carol McKenna are going to take us through this.
Do you want to start, Richard? Bring a social care perspective first, and then I'm happy to add.
That's fine. So we thought it'd be helpful to have this on the agenda, because there's obviously been quite a lot of publicity about pressures across the health and social care system, and they're a combination of the usual winter pressures exacerbated by some, particularly in the social care sector, some long-standing workforce challenges, particularly around recruitment and retention, to which the integrated care system responded by making available some NHS funding to bring forward pay uplifts that are national living wage that are due from April 2022. We brought that forward to December 2021 to help address some of the or help reduce the risk of a workforce loss. But sat alongside that, there's obviously been very high rates of COVID, which Emily has talked us through, and that's impacted on the availability of workforce both in residential and home care settings. So it's a combination of increased pressure, increased demand, and a reduced workforce, short and long-term reductions in workforce. The mean at the moment, there is quite a lot of prioritisation going on in terms of capacity. So as a local authority, for instance, we've been in discussion with families to whom we provide respite care about reducing the scale of some of that in order to free up staff to be able to go and work in some of our other services, particularly our older people's care homes, where we know it's critical that we've got a continuity of staffing levels, and it's very difficult to adjust those. But we've seen really good joint working across the system, so between local authority, Kirklees, but also Kirklees working with Calderdown Wakefield councils and with our colleagues, particularly in CHFT and Mid Yorkshire, to help manage some of the system flow pressures that they've got. And it feels quite a step change, really, some of those arrangements and where we were a couple of years ago, particularly that kind of collaboration across multiple footprints. So Kirklees Council's led the commissioning of some step-down beds on behalf of the 3 local authorities because we knew we'd get better value and system resilience if we commissioned a set of beds that we could use flexibly across all 3 local authorities. Okay, I don't know whether you want to pick up some of the other conversations that I know have been taking place through the Gold Command meetings. Thanks,
Richard. And I think it is important to highlight some of those things that you have done, you know, and examples around the, you know, bringing forward around the national living wage, for example, I think was a really important move for the partnership and signalled its support to social care. And I think that was a really positive move. The situation that Richard described in terms of staffing pressures, many of them have been seen in our providers as well. So in terms of our, you know, NHS services, if you like, they remain busy. There's no question about that. So you have the usual winter pressures that you see at this time of year, you know, with the COVID effect overlaid on them. And in particular, I think staffing, you know, staff sick levels have been a main driver of the pressure. So with our colleagues having to isolate for you know, for whatever the current period has been, that has clearly taken a number of staff out of our system, and that's been felt through our hospitals, community and primary care and everywhere else. Within our system, we've offered mutual aid and put staff in to support things like staff testing wherever possible. And it's really good, I think, that both of our acute trusts have been able to maintain their planned activity as far as they possibly can. Although in some exceptional circumstances, if you have large numbers of staff absent in a particular team, there will have been a few cancellations over the last few weeks, but there hasn't been any sort of blanket cancelling of activity as we've seen reported in the press in some other areas. So yeah, I think I'd probably just reinforce what you're saying, Richard, about how well the system is working together. It really does feel very, very positive. But I'm conscious that there's a couple of other colleagues, you know, from primary care and community and others on the call, so it may be that we've missed something, but that was all I was going to say today.
Could I ask if other colleagues who are, you know, from the trust or whatever, have any comments they want to add? No? Not seeing anything. I noticed Stacey Appleyard from Healthwatch has put a comment in the chat bar. Do you want to raise that as a question, Stacey?
Yeah, it was just really in relation to Richard's point around respite care being pulled back for some people, so obviously so we can move staff around the system. Just wondering if there was any pushback in terms of carers and families saying that actually they probably need the respite because they are, you know, are we seeing that we are pushing responsibilities back to carers again who are potentially unpaid to take up the slack for kind of the workforce and some of the pressures that we're seeing?
Thanks, Stacey. It's a very important point. So there were individualised conversations with every single family and a kind of negotiation with each of those families to understand the position they found themselves in. And in the case of respite care, it'll have been very much about rescheduling that. So it's, you know, if you look across the course of a year, it'll be not that someone has lost access to that service entirely. It's that we will have moved a booking by, you know, a period of weeks. But we absolutely recognise the criticality of respite care for individuals. And throughout the pandemic, even when we'd had to close some of our residential respite facilities in the first part of the pandemic for safety reasons, there were times nonetheless where we ran them, but with a single individual in them, because on the balance of risk and talking to IPC colleagues, that was the best outcome for that individual and family. And we kind of kept them safe by making sure they were the only individual there. And we also deployed staff and have again deployed staff to offer a different alternative. So actually it might be that we can provide people with a bit of a break in the daytime by deploying some of those staff who would have been needed in that residential facility to provide some daytime breaks. So creating a different offer. But yeah, absolutely, it's not been a blanket cessation. It's been an individual conversation. So there is still some respite being offered for those individuals for whom, the outcome of that conversation was really clear that actually the balance of risk meant it was better that we provide, and more importantly, we provided that respite than we freed up that member of staff to go and work somewhere else. And what we've then done is, in a sense, lived with the risk elsewhere in some of those other services.
Brilliant, thank you.
Yeah, that's really reassuring, Richard. Karen Jackson, you wanted to comment.
Thank you. Yeah, I think it's perhaps, Stacey, as well worth saying that for community services, and I know in other health service environments, the same kind of discussion has gone on, particularly as well around continually risk assessing the waiting list and the growth in the waiting list to make sure that there are no people on there who are decompensating and creating a clinical risk, and that has been absolutely front and centre to how we have reallocated our workforce and how we are then managing with carers and patients the position. Thank you.
Thank you, Karen. Dr. Khalid Naim.
Thank you. Just a brief on primary care situation, just to inform everybody that we've got a significant number of practices having positive COVID cases and staff absences because of that, self-isolation, and there are certain number of staff members who are off due to stress throughout this COVID. People are exhausted, people are demoralized, and it is causing a huge impact on primary care functioning and resilience, and some of the pressures in the system around our trusts, secondary care and community and mental health services. They also then cause more pressure in primary care, because that's the default position for people to call their GP for everything which is not going right in the healthcare system, and that again increases pressure. So we need to have some sort of concerted message that all the healthcare system is under a lot of pressure, so that people understand and people are patient with the staff members, and if there isn't any urgency to certain things, and if they can wait, they should let the system recover a bit. Thank you very much. Thank you.
Thank you. I'm not seeing any other hands up to comment or anything in the chat bar. Oh, I am. Ryan Hunter suddenly has appeared.
Yeah,
Hello, Ryan.
From a South West Yorkshire partnership, the Mental Health Trust perspective, we've got those same staffing challenges as well. A couple of weeks ago, we had around about 10% of our workforce off with COVID. That's dropped now to just over 4%, so it's improving, but there's significant challenges, particularly across our inpatient wards, where we've got a number of wards that have got COVID breakouts on them, so they're close to admissions, and we've got those same things with staff who have just I suppose working through it, but we've got burnout. It's difficult, but hopefully improving just with this current Omicron breakout. So that's where we are in Swift.
Thank you. It's another example of pressures on the system, and it makes life very difficult all around. Can I thank Richard Parry and Carol McKenna for taking us through that? Thank you very much. Can I move us on then to item 9, please, which is trauma-informed practice in Kirklees. And I've got down here Rebecca Elliott, Public Health Manager, and Stuart Horn, Head of Joint Commissioning Children and Families. I don't know which of you is leading on this.
Thank you, Councillor Kendrick. I'll introduce we have a team effort today for you, so thank you for having us.
Good.
So as well as myself and Rebecca, we've got Katharina Westwood from South West Yorkshire Trust, and Carrie Ray and M Irving, who are going to join us from the West Yorkshire Health and Care Partnership. So we're here today to talk about adversity, trauma and resilience, and We're going to talk a little bit about what that means and how we can implement it. And we're going to talk about some of the work that's been going on across the region and some of the commitments that have been made to developing trauma-informed working, which included some local leaders and directors signing up to a pledge to become more trauma-informed in our working in Kirklees and to work towards a trauma-informed system by 2030. It's not a new thing to us. There are lots of pockets of really good work going on across the Kirklees place, and late last year we carried out a mapping exercise to try and capture some of that, to try and kick us off to understand where we were at the moment, and we uncovered lots of really good quality individual work that people service areas were doing, and lots of things that were in development. So with that, I'll pass you over to Becky to take you through the slides. If we can share them, please, Phil.
Thanks, Stuart. Thanks, Phil. If you could just move on to the next slide, please. Thank you. So just following on from Stuart's introduction, we thought it'd be useful to put on a definition of what we actually mean by trauma in this context. So trauma represents the broad range of traumatic, abusive or neglectful experiences that people can experience or be subjected to during their lives. And the ambition that we wanted to talk to you about today is something that we want to achieve by 2030. So this isn't something that we want to achieve by the end of this year. This is very much a long-term vision that we're wanting to invest in and aspire to achieve. So that ambition is to become an all-age, trauma-informed and responsive organisation by 2030. The ambition is to develop appropriate and proportionate service change, both practically and culturally. We want to apply trauma-informed practice into all aspects of our work to further prevent harm for our residents and our staff. So this is what we're going to talk to you about today, but thankfully we're not starting from scratch, and as Stuart alluded to, we've already made some start on this work. Next slide, please, Phil. Thank you. So this will be familiar to most of you on the call, I'm sure, but we know that as the number of adverse childhood experiences increases, so does the risk for negative health outcomes. So you can see there the slide that demonstrates that, you know, this risk increases with the number of ACEs, as they're known, that people go through. And this isn't something that happens to other people. This is something that happens to all of us. So we know that around half of all adults living in England have experienced at least one form of adversity in their childhood. So this is something that is affecting a significant proportion of people, and it's something that we feel that we need to do more about and have a more consistent approach across Kirklees. Next slide, please, Phil. And here is some of the impacts of that trauma. So you can see here that it really is multifaceted in terms of the impact that it has on children, not just physically, but socially and mentally, and certainly in my area of work around public mental health. This is something that we see on a day-to-day basis, and it has long-lasting impact through people's life course. So it's really imperative that the earlier we start with some of these things, the better the outcomes will be. And I'll just pass on to Katerina for the next slide, please.
Thanks, Becky. Yeah, just to note before I discuss this next slide, it actually states commit suicide when obviously we don't commit suicide now, but it's just important to note that there's still some people and some work out there that still alludes to the statement commit suicide, and obviously it's not a criminal offence anymore, and it's important to acknowledge about this piece of work is about changing culture and language as well. So we would more refer to someone completing suicide or death is by suicide. So just a really important point there. So yeah, so people who have experienced trauma, so we're now certainly making connections between the determinants of health and obviously poor outcomes that the impact of trauma has on someone's well-being, physical and obviously mental health across the lifespan. And people who have experienced trauma are more likely to become addicted to alcohol, illicit substances, to utilise smoking, tobacco, vapes, to obviously come in contact more with primary care and indeed secondary mental health services, which in turn they may experience significant bouts of depression, anxiety, and may obviously require antidepressant medication, which may also lead to absences from work and also serious complications around relationships with others, job prospects, and education as well. And obviously, as I've just mentioned, people who have experienced trauma, there's a more increased likely chance of not only completing death by suicide, but also self-harming behaviours. I will also mention here that when we speak about trauma, particularly coming from a mental health nurse by background and someone who works in secondary mental health care, it's important to know that traumas we classify it as a trauma could be a big T or a little t. So your big T traumas could be your one significant life event, which could be a natural disaster, post-traumatic stress disorder, sexual violence, childhood abuse, and whereby your little t's could include more microaggression, for example, bullying or discrimination, social deprivation, or indeed many insignificant adverse childhood experiences as well. Thank you, Phil. Just for next slide. So to give this context and obviously to feed on from what Becky and Stuart said, we're working closely with obviously our regional partners, West Yorkshire Healthcare Partnership, who have signed up to become a trauma-informed responsive system. And we're definitely now seeing all system, including health, which is particularly the organisation I work for, social care, housing, third sector, and indeed loads of community initiatives out there that we're coming together to bring help and hope for people who are at significant risk or have experienced trauma. And I think it's very important as well in terms of shaping language and culture for staff to note here that people who have experienced trauma are certainly not condemned to a life of hopelessness or helplessness, and people can and certainly do recover from trauma, and this is why it's a very important initiative. Kirklees, Director of Public Health, have signed up to pledge to become a trauma-informed organisation by 2030. And what we mean by trauma-informed practice is that it's a strength-based, positive approach which seeks to understand and respond to the impact of trauma on people's lives. And it's definitely something that I advocate across the people I come into contact with. It's about us starting to consider asking people what's happened to them as opposed to what's wrong with them. Thank you, Phil. I'll hand back over to you, Becky. Thanks.
Thanks, Katerina. Thank you. So this just highlights the point I made before that we're not starting from scratch. So we've tried to pull together here a really quick overview of things that are already happening or have already happened in Kirklees. So I'll just pick out a few of these. So in relation to health, we've already had a session delivered to primary care colleagues around trauma-informed approaches. Swift, Katerina already is on the way with delivering some training around adversity, trauma and resilience, which I have been on, and it's fantastic training, and I learned lots about it on that training. We have some new mental health social prescribing link workers that are starting in Kirklees. I think some of them have actually already started, so that's a really fantastic opportunity in terms of the way that we work around trauma-informed practice in communities. And Em and Carrie, I'm sure I might mention this later, but we also have some trauma navigators that will be in post within Calderdale and Huddersfield Foundation Trust to try and help people get to the right place should they present at A&E. In terms of schoolwork, our educational psychology team have been delivering some emotion coaching, and Spen Valley High School have actually achieved an attachment award as part of that work. We also have the mental health in schools teams, which are operating in a significant number of schools across Kirklees as well. In relation to community, we are undertaking an antisocial behaviour review that Joe Richmond is leading on, and that's being done through a trauma-informed lens, which is fantastic. We've already got a mapping of services across Kirklees in relation to any service that's out there that's already providing something to do with trauma. So that's a great starting point for us to build upon. Huddersfield Police District are one of the first, well, I think they are the first police district to undergo some adversity trauma resilience training. So that's great for us in Kirklees, and we'll be keen to hear how that progresses. The domestic abuse strategy, as many of you will be aware of, is being written through a trauma-informed lens as well. And in terms of family things that are happening, in terms of the family context, we now have support for families where a young person has lost a parent or significant other to suicide. We now have postvention services for families in Kirklees, which wasn't available a year ago. That's now in place. And we have the family hub work and non-recent child sexual exploitation work that's taking place as well, all having elements around trauma-informed approaches. But what we really want to kind of raise the profile of today is not only all that work, but at the centre of it, what we really need is accountability and setting of milestones. And we'll touch upon this as we move forward. If you could just move on to the next slide, please, Phil. Thank you. So other areas to be discussed as part of this work. So this isn't to say that we're starting from scratch on some of these things, but we really want to sort of move forwards with our training pathways around this work. There'll be many teams across Kirklees that are already working in this way. And what we want to do is build on good practice that's already happening, but increase that staff competence and confidence in working in a trauma-informed way, asking those questions around what's happened to you rather than what's wrong with you, moving away from sort of treating the presenting physical issue and perhaps asking somebody what's happened to them in the past. We are a commissioning organisation, so we would like to have trauma-informed practice as a golden thread throughout all of our commissioning that we do. We've put staff and citizens on here because this isn't something that we just want to do for our population and our residents of Kirklees. Many of the staff groups that work in Kirklees will be supporting people who've experienced trauma, and therefore they will be listening to things day in, day out that have happened. They'll build up strong relationships with the people that they work with. So it's about how we actually look after our own staff, and many of our staff may have had trauma in their past as well. So it's not about something that we're trying to do to other people, it's about all of us. The Healthcare Partnership are developing and having discussions around kite marks for trauma-informed organisations, and this isn't something that's wanting to be tick box, something like a tick box for us to do. It's something really around providing us with key indicators as to how we can improve upon becoming a trauma-informed organisation. Something that's really important is the balance between prevention and intervention, and we hear this being spoken about quite a lot within the Healthcare Partnership meetings. That, you know, if we're talking about people who've experienced trauma, we don't want to just think about what we do as a result of that trauma. We also want to think about how we can prevent the trauma happening in the first place. So this is very much a prevention agenda as well as understanding what we can do and change once trauma has been experienced. And a really interesting point for those of you that work within mental health, we often talk about mental health recovery, and there's a bit of a challenge within this work to move more to talking about discovery rather than recovery. Recovery can often give off sort of connotations that the person has completely recovered and what's ever happened to them no longer is relevant. And I think within a trauma-informed lens, it's about how we move to more of a discovery phase and how people learn to live well with what's happened to them. Obviously, within the council, we'd have a lot of work going on around restorative approaches. So we don't want to confuse those pieces of work. So it's very much about how this links with the work that we're already doing around restorative working. And as we've already alluded to in the previous discussions that I just heard the end of, in terms of our COVID recovery, this is really, really important for not just people who've lost people, but you know, all of our staff and our workforce that have been under significant huge pressures during this time. Thank you, Phil. I'll pass over to Carrie and Em for the next two slides, please.
Thanks, Becky. Two apologies. One, if I'm a bit croaky, I'm sorry, I am full of cold. And the second is, I'm really sorry I can't see you. My camera's been deactivated. They don't like us from the central team. So I'm Em, and I'm Senior Manager for Improving Population Health within West Yorkshire Health and Care Partnership, but I'm also the Public Health Lead for the West Yorkshire Violence Reduction Unit. So just to set the scene, this programme of work is a joint piece of work between the Violence Reduction Unit and the partnership, because we cannot address trauma adversity across West Yorkshire unless we're working across all sectors. Oh, I've been given permission. You can see me all again now. Unless we work across all sectors, it is not in the gift of one organisation to be able to change this. As Becky said earlier, it's absolutely about culture change, and that's why the ambition is a long ambition to 2030. And that doesn't mean by 2030 this will all be done and dusted and ticked off. This is something we'll continuously have to work on. But to get from the culture change and to get the prevention angle that Becky's spoken about, we do need to have that time to work together and look at what our roles are and look at how we can respond to trauma, but also look at how we can work with our communities, which is vitally important. So we have a community action collective across West Yorkshire, which brings together people with lived experience. It brings together our voluntary community sector leads. It brings together people from statutory organisations to look at how we can co-produce this work moving forward and raise awareness of trauma and adversity with our population. So this has started actually with a really interesting discussion about we want to co-produce, but actually we're co-producing in a trauma-informed way. So our first point of call for that is to look at how we co-produce and we're creating a value and ethics framework that will support that, and that's being led by Lisa Cherry, who's an expert in the field that's working closely with us. We want to develop the strategy. So this piece of work has been ongoing for a year and a bit. We started it right at the beginning of the pandemic, which was amazing because obviously there was a bit of a distraction at the time for lots of people, but we still had over 50 people come to the network wanting to take this work forward. And we had a knowledge exchange in March, a 3-day knowledge exchange, which brought even more partners to the table. And the network, as Carrie will mention in a minute, has got quite a large membership as a result. And what we're doing is we're working with every sector across West Yorkshire. So Becky mentioned the training with police. It's actually the whole of Kirklees district response teams that are receiving the training over the next 10 weeks. Training each team, there's 5 district response teams. The training began 2 weeks ago, and Dr. Warren Larkin is doing that. He's going to provide a summary at the end of each training session, which we can share to tell us how things are going. We're training all housing staff across West Yorkshire. Every housing organisation, including those within Kirklees, have signed up to that. We've got a primary care pilot of training that's about to start in Calderdale. Once that pilot's done in Calderdale, it will then be rolled out. But if any other areas at the time want to be involved in the work, more than happy for them to do so. Becky mentioned the work in Calderdale and Huddersfield Foundation Trust. We're putting, I don't know if you're aware that Leeds and Bradford have had A&E navigators for the past 12 months, and they're providing a really valuable service around reducing knife crime and hospital admissions. And we're seeing a significant amount of young people referred through both services. And what they're doing is they're being picked up in A&E. They get that teachable moment from a navigator, but then they're referred into a community links based service in community for long-term ongoing support. Now, we know in Kirklees there's an increase in prevalence around young people, serious violence and knife crime, but we know in Calderdale it's slightly different. It's more mental health, it's the adult population. So we're putting in trauma-informed navigators into CHFT, and they'll sit on both sites. And in Kirklees, they will deal with whatever comes through the door, probably around serious violence, and in Calderdale will meet their needs. And that's being part funded by some targeted violence prevention funding that came from NHS England. And we're rolling this out across the whole of the system. So Mid-Yorks and Bradford, Mid-Yorks and other areas are expanding to cover trauma and adversity and not just the serious violence. What we do know and why we think this is so important is those root causes. And if any of you have had a chance to see the Child of the North report, It's really interesting, and that's showing us actually that the children in the north of England they just don't all have the best start, and actually in comparison to their counterparts in the south of England, it's quite stark. So if we don't address this situation, this life cycle of trauma is going to continue. So we want to make sure we're addressing it all the way from preconception right through and continuing. And somebody said this morning on our Consortium for adults facing multiple disadvantage that it's not a life course, it's a life cycle, and they're absolutely right, because we've got to break down that intergenerational trauma and adversity. So training is a big part of this programme, but it's not the be all and end all. We can train people. That doesn't mean to say we're a trauma informed system. So we need the training, we need the understanding, but we have to have the responsive services, we have to have pathways, we have to have access to services, and we have to have an understanding of what the unique needs are of our population, which of course you guys at Place all know that more too well than I do. I'm going to pass over to Carrie, who's going to give us a bit more information about our governance structure and tell you a bit about how the programme's sort of pulled together.
Thanks, Em. So hi everyone, I'm Carrie. I'm the Programme Manager for the Children, Young People and Families programme in the West Yorkshire Health and Care Partnership, and jointly co-lead this programme with Em and the Violence Reduction Unit. So just in terms of our governance structure, as Em has adhered to as well, this is a real whole system approach, and it needs to be, because we need to get this right as a whole system. We have got a Chief Exec lead for this work, and that is Kirsten England, who is the Chief Exec at Bradford District Council, and she is our Chief Exec lead in helping us take this work forward. So at the top, we report into the VRU Strategic Executive Group and our System Leadership Executive Group in the Partnership and the Clinical Forum, who we've presented this work at and who have supported this work progressing. We then have our Programme Board and the Partnership Delivery Group underneath that. And we have our Strategic Board, which Kirsten chairs, where we look at any funding arrangements, bids, the governance around this, the progress as well. What's really important for us is the boxes on the left around our 5 districts across West Yorkshire Partnership, and we really want this system approach to be working in partnership with each place, but also we're looking at where we work together as a system to really support that delivery and where we can do things once. As Em said, this has to be delivered close to communities, but there are a number of areas of work where we can work together as a system, which really takes that pressure and capacity off each place, but also adds that intelligence and capacity and resource into the system as well. So underneath our strategy board, we have a network, which is primarily really focused on preconception to 25. After our knowledge exchange, membership at that network absolutely quadrupled. I think we have about 70 members now from all sectors across the system. And we really look at how we shape the work going forward. And we're going to be theming some of those network meetings going forward as well. We recently had one around trauma-informed education settings and opened the invite wider. We're going to have a meeting on criminal justice in February and theme some of those to look at trauma-informed organisations as well. We've got a number of organisations across West Yorkshire really wanting to lead the way in becoming trauma-informed, and how we can all learn from each other and take that approach together. And from that group, we're going to produce a bit of a resource pack that organisations can use to guide them in being trauma informed. We've got our West Yorkshire Consortium for Adults Facing Multiple Adversity, which is looking at that 18+ age range, and there are members, many members from Kirklees on a number of these groups as well. We had a really good meeting this morning where DWP were at it and are really keen to work with us as well on this programme of work to look at them becoming trauma informed and how we can work in partnership on that as well. So as I said, lots of different sectors and organisations. Got our family resilience and early help group, and we're looking with the development of family hubs, how that can be done through a trauma informed lens. Em's touched on the training collaborative and the community action collective. Trauma informed education settings, we've just starting our first meeting on the 28th of January. Lisa Cherry supporting that work with us as well. and we'll be looking at what we can do together, and we're looking at having a bit of a symposium around that to start looking at that work and taking it forward. There's also a piece of research which will be being undertaken, funded by the Violence Reduction Unit, around trauma-informed education. We'll be looking at that research to drive that work forward, as well as a system. We've touched on some of the primary and secondary care elements of it, and then some of the future work streams that we're looking at around looked after children, criminal justice, and had a really good meeting with Armley Prison earlier this week. The Governor is really, really keen to engage with us on this and look at how there could be a trauma-informed prison setting as well. So there's huge amounts going on, and really where we're hoping we're adding that value in terms of our programme is really supporting place with the delivery, with some pilots that we can share across the system, looking at where we've got gaps such as training that we can do once as well. And just at the bottom is our scaffold of common principles that's really key to this, around the senior leadership, the partnership working. Prevention is key in all of this as well, and that is why our ambition is up to 2030, because we want to look at preventing trauma occurring where we can as well, and that early intervention element of this being really important. So I think I just hand back to Becky.
It's actually
Thanks,
me,
Carrie. I think it's going to Stuart.
Thank you. So what are the next steps then? I think that's given us a good introduction if it's new to you, or a good background of what's happening regionally and already in Kirklees. But we recognise it's a huge task to work towards this ambition, and we recognise that to do that we would need to secure some additional resources to help us to coordinate this approach. There was a national funding bid last year, which we bid for as a West Yorkshire collective for some additional resource, but unfortunately we weren't successful in that bid, so we need to look more locally within our own organisations as to how we can support this agenda. We've recently identified some funding from the CCG to support the development of trauma-informed work in our youth justice service. I so recently informed that I don't think I've even told my colleagues on the call today. That was only yesterday we found that pot of money. So we decided it would be useful for us to develop an adversity trauma resilience action plan for Kirklees, which complements some of the good work that's already been undertaken by colleagues at Swift and in the Health and Care Partnership, building on some of the resources and training materials that have already been developed rather than reinventing anything. It's also important to develop a steering group so to take forward the action plan and develop our approach to tackling our ambitions. We also thought that it'd be useful to have a training and development session for senior leaders in Kirklees to go into greater depth about understanding the issues and the approach. So that's next slide, please, Phil. Did you want to come in, Em, at this point?
Just on what you were saying about criminal justice, and just to say that I had a meeting with, is it Diane Lowe from Kirklees Youth Justice Service, and I'm attending their meeting on Monday to start Kirklees as a pilot around that, and potentially expanding to looked after children as well. And that was just, I think, a couple of days ago I had that conversation.
Excellent, thank you. So thinking about what we need from the Health and Wellbeing Board today, what we've come for. So we've really come for the support of the board and endorsement from member organisations to support this ambition and to help us to take forward this piece of work, and in particular endorsement for how we identify any extra capacity that we might need to help lead and drive forward. So with that, I'd like to open it up to any questions or discussion, please, Councillor Kendrick.
Thank you. I know earlier on Dr. Naim had his hand up. Can I just say in the chat, there's been a fair bit of thing. We've been promised that the slides would be shared. If they could go to Jenny in our governance, she'll make sure they get out. And I'm glad you clarified about the training with the police was much wider than just Huddersfield. And James Griffiths has said feedback so far has been extremely positive, so that's really good. Were you wanting to come in with a question or a comment, Khalid?
Thanks, Viv. Excellent work. I think you only start realizing it once you look at, you know, the outcomes of some of the people who have gone through trauma, and all the figures which are put on the slides, and it's quite powerful information. I think you know, for prevention agenda, we need an Emily Perry Harris for mental health. I think we need to have either you know, public health having a mental health prevention, you know, part of their agenda, or we need to have a separate, you know, separate service, you know, which works with SWIFT, you know, and then work with different organizations, and for future prevention of these things. It starts in childhood, so we should be looking at how we can prevent this happening in our children. So school staff would be a good place to begin to, you know, to have that informed, you know, training. Thank you.
Thank you for that. Someone's got their hand up in the, and I don't know who it is because it's just showing +11. Right,
it was
go
me,
ahead.
Councillor Khan. Absolutely, Khalid, thank you for your point about public health being involved. And obviously Becky is part of my team in the public health team in the council, and has a really central role in this piece of work. And we continue to work very closely with and colleagues at West Yorkshire. So I chair the prevention network at a West Yorkshire level as well. So Em and I spend a lot of time together talking about that, and I'm also very involved in the version of that meeting that you look after, Carrie, that I can't remember what it's called. I'm so involved I've forgotten the title of it. But the meeting where we meet to talk specifically about children and young people. So we have lots of opportunities to feed into these conversations, but the most important leadership of this work within public health sits with Becky, and she does a brilliant job too.
Emmeline Irving, do you want to come in?
Thank you. Yeah, and Emily, it's preconception to early years is the group you were
Go on.
thinking of. There you go.
That's
So there's the preconception to early years steering group, which Cathy Monroe and Vicky Signicki from Kirklees sit on, and there's a few other colleagues. Is it Janet from Locala, Carrie, that sits on that group? And then we have obviously the prevention network. Yes, I thought so. Thanks, Karen. And then we have the prevention network, and actually there is key, because to get this right, you're absolutely right, Khalid. We've got to look at education and from early years. We've got to look at this from preconception and that cycle of trauma. We know that children that are born into families where you've got domestic abuse, for example, are then likely to in turn eventually become abusers themselves. So we really have to start there, and it's those levels of deprivation, it's the poverty, it's all the things that underpin general risky behaviour that cause this. So we can't look at it in isolation to prevention or any other agenda. Physical activity is a massive protective factor, as is good sleep. So they're the type of things we want to look at. The other thing to mention is we're also working to look at this through the lens of the ICS of Sanctuary as well. So I'm not sure if you're aware of the West Yorkshire's ICS of Sanctuary work. That's also coming through my programme in improving population health, being led by Paula Sheriff. And that's really looking at how we sign up to that as a whole system. And we're looking at that through a trauma-informed lens, as well as our links with the local maternity service. I saw Carol pop a camera back on there. And the local maternity system, we're also linked heavily with that and looking at how we put this through maternity and all those different avenues. So it's big, but if we get this right, this is one opportunity to really make a difference and reduce all those things collectively that we're trying to do. And just to mention, Wakefield is the other district where the police training has started as well.
Thank you. It's certainly given me a lot of things to think about, and at risk of expanding this even bigger than you think it is, perhaps. And I know there's been mention of children who are looked after, but you only need to talk to some of our children, and it'd be the same across other authorities who are looked after and our care leavers. The very fact of coming into care is at least a small T, and for many, many a big T. And I think there has to be some very concentrated work. We have an ambition for children to have the best start in life to achieve, and I think this gets in the way of that for many of our young people. So it's something really, really active, not just the children who are on the edge of getting into the youth justice system. It is the very fact of people. I think very often the public think, oh, if they've gone into care, they're safe. Physical safety isn't the end of it, as you all well know. And I would like to see some concerted effort looking at that too. But thank you very much. Carol McKenna has her hand up.
I do, but it's not about maternity. This might be a really small point, so forgive me if I found it a really, really helpful presentation, but there was just something about the language I wanted to pick up, so sorry if it feels a bit pedantic. I had to take a call at the beginning, but when I clocked back in, I heard Katerina explaining the bit about changing the leaflet and the presentation around the language on suicide, and absolutely, totally support that. I think the other thing I would suggest maybe having a look at is when you describe alcoholism. So the way Katerina described about becoming addicted to alcohol, I think absolutely using the phrase become an alcoholic is labelling someone. And I don't think we define people by their illness anymore. You know, the days have gone where we said someone was a schizophrenic or whatever it might be. And I think we shouldn't do it with addiction either. So sorry if it's a bit of a nitpicky point. I try not to do that, but it kind of jumped out at me.
Absolutely, Carol. Language is huge, and we're going to have a specific focus around language in the strategy. That slide, I think we're going to have redone as a West Yorkshire slide, because it's a very, very powerful slide, but we stole it from somewhere else, which means that we haven't been able to change the language on it. But we're going to do it's like we don't use ACEs. We don't use the acronym at all, because there is nothing ACE about this conversation. So if we use adverse childhood experiences, we say adverse childhood experiences. So there's going to be lots and lots of work around language. It's not a small point, it's a huge point.
It's something that comes out of all our meetings, Carol, about how we get this right and meaningful, and the term resilience as well. A lot of people aren't too keen on that because it puts a bit of an emphasis on the individual.
Yeah, it's become quite overused, that, hasn't it? Resilience as well, I think. Yeah.
I can see someone else's hand up, please, and I'm aware of time ticking, but not that this isn't vitally important, but there are some other important things too. Who's got the hand up that I can't see?
It was me, Viv, back. I'll put it back down again. It's fine if we need to move along.
I do. Can I just thank all of you? You're a bit of a cast of thousands for coming and presenting this, but it's certainly chimed with, I think, people on the board and has been of great importance. And I think it's a conversation that has to be ongoing, actually, for us to do more with that. But thank you so much for that. And I think board members are invigorated, enticed, want to know more, want to do more. So, you know, excellent. Thank you very much.
Thank you.
Thank you.
Can I move on to item 10, please, which is responding to strategic and current tactical workforce issues in Kirklees. We do have some fun titles. Karen Jackson, you're going to do this for us. I can't hear anything, Karen. I don't know if you're on mute.
I'm talking to myself. Apologies.
That's all right.
Much of what we've been talking about today has linked in various ways into the health and care workforce right across all partners. So I'm not just talking about health and social care. I'm thinking about third sector, care homes, etc. And at one of our partnership meetings, I raised the issue of the pressure in workforce and the way that we needed to work together. And it's a bit of be careful what you wish for. So I agreed to do a piece of work with all of the colleagues across the patch, and a lot of those people are on this call, so just a shout out to them to say thank you. So this work has been done by the partnership, and the paper that we've generated is going to the partnership board on the 3rd of February, but we thought we'd do you an update here, and folk can chip in as we go along because they have been engaged. Like I say, can I have the next slide, please, Phil? Thank you. So here are some of the current challenges, and I'm not going to read them all because we know about them all already. I think it's worth just highlighting a few of them, though. We know that for some specialties, there are issues of national shortage of colleagues, skilled colleagues. And we know that that presents pressure in our system. So in addition to having to deal with people who are on sick leave due to things like COVID, etc., and stress, we also have national shortages, which means that we get into redeploying our colleagues to cover those too. We know there are differential pay rates across sectors, and Richard and I often have this conversation about differential pay rates, and all of the things that we all well know about impact on the well-being of our colleagues, but importantly, the stable delivery of care in our system. And there has been a bit of an issue about us moving staff around the system, so advertising posts in various partners and moving staff around the system without actually any overall growth in the capacity of people that we have to care. So we know this is multifaceted, but we need to tackle this as a system together in order to shift that dynamic and to maintain our colleagues' wellbeing, which is really important. Can I have the next slide, Phil, please? Thank you. And I think it's also worth saying there has been an awful lot of positive work done today, much of which has been led by the workforce group chaired by Steve Brennan. We've been really clear to match this work with the wellbeing plan across the whole of the ICS. There's lots of engagement with the school programme promoting our sector in schools. There's lots of health and wellbeing initiatives that are going on to maintain the wellbeing of our current colleagues. And we are really clear about supporting flexibility and caring responsibility so that people can remain in our employment and we support them to be in that place together. Can you move on a slide, please, Phil? So, like I say, we've had a bit of a timeout, let's call it, with partners from across the whole of the sector, including the third sector, like I've said, and I've been very grateful for their input. And there are some proposals that, like I say, I'll be going to the 3rd of February meeting. This is just the outline. So we do think it's really important that we focus on our workforce representing the community which we serve, and we know there's much more work we need to do around there. We think it's really important we have some kind of agreement between all partners to be developed so that we can do things like recognise continuity of service between partners. We can think about models of employing to deploying, so we don't all have to employ particular groups of staff. If they're difficult to find, we can train and employ in one place and deploy them across our whole system. We think it's important that we have rotational or dual role models, and that's important to encourage people to come to the system in that they will get a really broad experience of different segments of our system, but also the development opportunity. We know there are issues in social care, and one of the suggestions has been about differential tiers and about how we reward those differential tiers for the complexity with which they are dealing with on a daily basis. And a really important piece between all partners and colleagues about myth busting, so that we understand better what we're all dealing with and develop that trust and respect of each other. Can I have the next slide, please, which is some more proposals. We want to continue to work with the education sector and perhaps develop more work experience, and we want to share that development with shared training and professional development. We think we can do that much more effectively and creatively. We think there's a huge piece of work we can do around the volunteer workforce, particularly around young volunteers as well, back to the encouraging people into the sector. And we've got befriending schemes. we think the consistency of communication between colleagues needs to be worked on. And we do want to improve our processes so that we don't have huge processes to go through. You know, if you're faced with a online CV that keeps crashing and is 50 pages long, it's a bit of a turn off, isn't it? So there's work we believe we can do in that area. Thanks, Phil. So like I've said, the next steps, the proposals that I've just outlined to you will go in much more detail to the Integrated Health and Care Board on the 3rd of February, including, well, how are we going to resource this? And how are we going to drive it forward and hold it together in a coordinated way? Thanks, Phil. And so we just wanted to, in terms of recommendation for this meeting, we wanted first of all to recognise the extraordinary effort that's been made continually, but particularly over the last 2 years of colleagues, and the situation of pressure that presents to people. We've talked about that earlier in the meeting. We would like the board to welcome the approach to develop this across the place so that we can plan for the longer term, but also deal with short-term issues in our workforce. And agree for us to come back to future meetings to update on the work that's happening and the progress that we're making. Do you want to unshare there, Phil? And if it's okay, Councillor Kendrick, I'll just ask if any of my colleagues who were involved in the work would like to pitch in. Can't hear you, Viv.
But somebody's put the hand up, but I can't see who it is.
It's Phil.
It's Phil.
Thanks. We had catch up amongst the people who are in similar roles to me in terms of adult social care workforce across West Yorkshire earlier in the week, and one of the things that really struck us all was the point about understanding across the system of the reality of work in different bits of the system. So there aren't many people who work in social care who actually know what it's like to be on a ward. There aren't many people who work in primary care who know what it's like to work in a care home. And we were all very excited by what they do in Calderdale, which is good, because they've got a programme where they spend a day walking in other people's shoes. And one of the things we undertook to do as a bunch of people from a social care perspective was basically test that idea out and see if people in each of our 5 places would be willing to do that. And I think one of the opportunities for the board is to demonstrate a bit of leadership, because if Khalid could spend half a day working with some people in domiciliary care, I think that would be fantastic. Similarly, if some people who run care homes could perhaps spend a bit of time working in or shadowing people who are doing community nursing work in the so a way of getting people to understand a bit more, not by watching a video or coming to a meeting, but getting out there and actually seeing what work looks like for real.
Okay, an interesting suggestion as such. I have to say, I think it's a fascinating piece of work so far. I mean, I'm intrigued by some of the ideas that you were expressing, and I'm hoping I'm speaking on behalf of the whole board that we do welcome this, because I think it's fascinating. I have to say, on social media, I have never seen so many job adverts for care providers in my life. They ping into my phone all the time. I must have signed up for something. Not that I'm going into doing care as such. So I think we very much welcome some further report back and feedback to the board. I'm not seeing anybody else wanting to make a comment or question. But can I thank you for a very, very comprehensive run through that, Karen?
Thank you, and we'll bring something back then. I'll organise with Phil. Thanks very much.
Thank you. Thank you. So if I can move us on to item 11, please. Last but not least, it's Carol McKenna going to talk to us about Kirklees Place-Based Partnership and West Yorkshire Integrated Care System.
Thank you, Chair. I have a few slides and I will promise to go through them as quickly as I can. Now, Phil is going to have to drive the slides for me because I don't have the relevant permissions, apparently. So are you okay to bring the slides up, Phil? Lovely, thank you. Move on to the first one then. So this is an opportunity just to bring colleagues up to speed, and the particular things I wanted to focus on today were a little bit about the delay in the implementation of the new arrangements. Some feedback about a conversation we've had in relation to our partnership name, a little bit of information on the collaboration agreement, and then some update on where we are with some of the senior leadership appointments to support the transition to the Integrated Care Board and the place-based partnership. So if I can move on to the first one. So as you probably know by now, the target date for the move to the statutory ICS was the 1st of April 2022. The target date is now the 1st of July 2022, and that was announced just before Christmas. So that is something that will have changed since the last time we spoke. In terms of what that means for us in West Yorkshire, the general view is that there's absolutely no change in direction or the journey that we're on. We are carrying on, and we've put a lot of things in place already to help us transition into the new world. So we're absolutely going along the right lines. There are some technical implications of this. So colleagues who work in the areas of finance and governance probably are the ones who are most likely to be affected by having to do some things very close together. So, do 2 year-end processes for finance within the space of 3 months, for example. It does cause some challenges, but not impossible. Just a bit more work in that area. And it does mean that the CCG statutory responsibilities will continue until the 30th of June. So, having said that, we do want to be in a position where we're operating the new arrangements in shadow form from April, recognising that there will need to be an underpinning of the CCG governance arrangements, because sometimes there may need to be decisions taken in that period that legally still sit with the CCG. But the CCG needs to take those decisions in the knowledge that they are supported by the new partnership arrangements. So it's a bit clunky, I think, maybe the best way of describing it, but we will navigate our way through it. We have done it before through various changes in organisation, but that's the situation as to where we are now. If I can have the next slide, Phil, please. And this really is a slide that Laura produced, Laura Ellis, and I think it's really helpful and helps us understand what that means. So within January to March, which is where we are now, we're continuing the development and starting to shadow some of the new forums that we have in place that you can see down the left-hand side. Then from April to June, there is that shadow period that I talked about. And you can see that for some arrangements, like the Health and Wellbeing Board, for example, that will just continue. That's not affected in sort of other than in the way we talked about previously, and that we might want to think about our focus, etc., etc. But it remains in statute and it continues. Whereas for some of the other examples, if you have a look right at the bottom where it says about CCG existing governance arrangements, you can see that there are some things that need to continue, but other things that will start to stop as we move into April and June, and then obviously there would be the full go live date in July. So we shared this with the Integrated Leadership Board last week, 2 weeks ago now, and people were comfortable with that approach. So if I can, next slide, please. And then the other thing we've been having a really good conversation about is, what do we call ourselves as a Kirklees partnership? So any of the documentation you read about this talks about, place-based partnerships as part of the ICS, but we thought we would like to be able to, create an identity for ourselves that we can use in our branding and our communications. So through the through the design group that we have formed that brings together a number of partners, we conducted some engagement during November and got 60 responses back, actually, which we thought was quite a decent response rate given everything that was going on. A number of partners came back to us with their views on what would be a good name for the partnership, and some of that included some of the keywords that they thought they would like to have included. And the clear preference emerged from that, which was that we should call ourselves the Kirklees Health and Care Partnership. And you might think, oh, that's not very radical, but equally, I think people felt, let's have something that describes what we're there to do, rather than something that sounds like a bit of a catchy name, but then you have to then go on to describe what it actually is. So the strong view from that work was that that is what we should be called, and we took that to the Integrated Health and Care Leadership Board in January, earlier this month, who approved that recommendation, and hopefully you will support that today and start to see that terminology being used in some of our communications. So if we have the next one. Okay, so this is some of the technical stuff that will underpin the workings of the Kirklees Health and Care Partnership. Let's start using the new name. So each place within the ICS is developing a collaboration agreement, and that is for each of the partners to sign up to set out how we intend to work together to deliver our shared vision and how we will act, you know, how we will do business, and really sort of set out our support for the collaborative principles and the way we want to work. So that would become effective from the 1st of July. It's in development at the moment, and we'd be seeking partner agreement on that between April and June. It's important to say that signing that agreement, entering into it, in no way trumps the respective duties of partners. You know, every statutory body has duties and existing governance arrangements that it works within, and this doesn't overrule them. The work programme that will reflect in that will be the Kirklees Health and Wellbeing Plan. And we have been at pains to say to people it is not going to be a legally binding document. I think for big statutory bodies, signing things that are legally binding probably isn't something that causes too much angst, but sometimes maybe for some of our smaller partners and others, they might feel quite anxious about signing something like that. So we're going down the route of not having it as a legally binding document, but obviously want people to sign it in good faith, so that it does have meaning. And the expectation is that that'll evolve during 22-23 and beyond. And actually, you could say that for this whole thing. You know, every aspect of the partnership will evolve and develop as the new world starts to take shape, and the collaboration agreement will need to be able to reflect that. So if I can move on to the next, just last couple of slides. So in line with the, you know, not letting the delay slow us down and getting on with putting the new arrangements in place, some senior leadership appointments have been made and announced this week. So you'll know from past presentations that we've said it was always the intention that each of the 5 places would have someone who would be the nominated place lead, and the sort of official title for that post holder will be the accountable officer, brackets, you know, Kirklees, brackets, Calderdale, whatever. And the appointments to those roles have been made. So I'm really pleased to say that I'm going to be carrying on in Kirklees in that role. It does mean you haven't seen the last of me yet, I'm afraid. I know I've known a lot of you for a very long time. But I am really pleased that I'm still going to be around in that role in the patch. And actually, just on that, the challenge that was made during Karen's presentation there about people walking in each other's shoes and getting out and, you know, seeing how different sectors operate. I think it's a challenge I would really like to take up as I move into this role as well, and that's something I will be pursuing in the next few months about how I can actually really sort of get out there and learn more and understand more about what all of the sectors in the place are doing and the challenges that they're facing. And then the other appointment, which is one of the directors on the ICB board, is Ian Holmes. He's been appointed into that role, the Designate Director of Strategy and Partnerships. Some of you will be familiar with Ian because he's attended this meeting a few times to talk about the development of the ICS. Okay, and finally on appointment. So as Laura mentioned in our development session earlier, we are now out to recruitment for the place-based independent chair and independent members. They are part of the committee of the ICB in Kirklees. The advert was launched this week and the closing date is the 5th of February. And the information on that's going to be widely circulated through our partnership networks. And in terms of identifying partner members for the committee of the ICB in Kirklees, we will be managing that in due course when we're ready to send out information packs and information on that, and we'll be asking all the partners to nominate their representative on that board. And then finally, going back to West Yorkshire level, the ICB board, the recruitment process is underway now for the 4 executive posts mentioned there and another 3 independent members, I believe. I think all of them have closed with the possible exception of the independent members, but don't hold me to that. But the process is certainly underway, and I know that interviews start in the next couple of weeks for them. So we'll start to see over the next few weeks, next month or so, more and more of the senior leadership posts being appointed to, and that will start to give some shape to all of this, and we will know who's going to be doing what. So I think, Chair, I think I'll leave it there. I think that's my last slide, Phil, isn't it? I've not forgotten about one at the end. No. Thank you.
Thank you very much, Carol. Oh, I was echoing a bit then. Could I say, oh, I've got an echo in the background here. I don't know why. I know I'm happy to see that you're willing to accept the challenge to try somebody else's shoes on, and Karen Jackson is happy to take that challenge as well. So I hope there'll be others joining you in that. I don't know what colleagues' view is, but it seems to me that Kirklees Health and Care Partnership says what it should be on the tin, really. It's nice and clear. It isn't a mile long, and it says it all. So I hope the board are happy to endorse that as well. And I think it's absolutely right to emphasise that actually the health and wellbeing plan will be the work programme, you know, and people need to understand and be assured by that. And I think finally, and I'm not seeing any questions coming up as such or comments, but congratulations to you, Carol McKenna. You may have been around a long time. I'm happy you're still with us. That's wonderful.
Thank you. Yeah, I'll take that, Viv. Yes, I have.
Sounds a bit rude. You've been around a long time. I didn't mean it in that way.
No. 22 years in Kirklees this month, Viv.
Wow. Well, it's a wealth of knowledge and experience we can't afford to lose, isn't it? So I'm not seeing any comments or questions, so I'm going to conclude the meeting at that. Can I thank everybody for their attendance, and particularly everybody for their contributions? I think it's been a very interesting and stimulating meeting. And to note, please, that our next meeting will be on the 31st of March 2022. I'm still having to get used to saying 2022. I'm a bit slow on the uptake at times, but there we are. But thank you all very much for your attendance, and we're about right on time. So thank you and goodbye. Bye-bye.